capacity, so I will project as best I can. Allergies are already killing me. I shouldn't say already. It usually starts earlier in the year than it did this year. So we have a couple hours. I have a presentation, but that's not the whole topic for the morning. Usually I like to start these opportunities with any questions people have, anything you want to put on the list of things to talk about. The second hour we'll probably do some charts. So if there's a chart that you really want reviewed and talked about, you can shout that out to Captain Ray and see if we can get that pulled up. Otherwise we have a few charts that we'll bring up. And also I'm following what looked like a great presentation this morning. If there's any follow-on questions from that, we can discuss any of that first.
Yeah, I got a question, just because some of us who were on the call were in the room, and it's more kind of a legal thing. Police had responded for a pickup order for someone who had, I think, made a suicidal statement, and it was called in by the physician that she had spoken to on the phone. Anyway, when they got there, because of, I think it was either a wound she had on her leg or something like that, they requested that we transport her. And Cook, do you remember that call? And you were saying, well,
Yeah.
because it's a pickup order, I don't know that we have the authority to.
And we didn't have the authority, and the other thing was that pickup order was 10 days old or something like that. It was super old.
It was just, there was kind of some nuance in that call, so maybe you can remember the details better.
It was, they came to pick up, they couldn't transport her because she had a wound on the back of her leg. She couldn't sit in the back of a patrol car. She denied SI for us.
She was
Denied SI
elderly,
for the police.
was the context.
She was also elderly.
Yeah, these are, so the pickup orders, as you guys have kind of alluded to, is a law enforcement order. It's not an EMS order. So those orders are specifically faxed to law enforcement for them to do, to execute that and bring that person in for evaluation. It is not uncommon for those individuals to have, when law enforcement gets there, for them to identify medical issues or difficulties with transport for whatever reason. They're bedridden and they're on oxygen, whatever it is that they're uncomfortable transporting, and that's when we get engaged in those, and that can be challenging. If most of the time when that happens, it's fairly straightforward in the sense that it's pretty clear that they do need our capabilities for whatever issue, and the patient is either agreeable and cooperative with that for us, or they clearly do not, they meet our criteria for needing involuntary care, whether law enforcement was there or not. So if it meets those criteria, then we absolutely can assist. Where it gets challenging, which is what I think you're describing, is the situation where law enforcement got a pickup order, they call us for whatever reason, and then we have a patient who is not cooperative with going with us, is refusing care, and seems to meet our criteria for refusal of care. And the one thing we can say for sure in that is the law enforcement order does not mandate that we transport a patient who does not otherwise meet our criteria, which it sounds like is what happened here. We do occasionally, those are often consortium phone calls, as you can imagine, not our favorite phone calls, but, and sometimes they get very convoluted, and because what has happened several times is the way those work is, what often happens on a pickup order is a provider's office gets some kind of secondhand information. The most common thing that I've seen is that somebody calls their primary care for an appointment, and the office says, hey, we can't fit you in for whatever, and they're like, well, fine, I'll just kill myself. Right? Now, sometimes that generates a 911 call, right? We see those all the time, but sometimes they have that stack of forms there and they're like, oh, we'll send a pickup order, and have the police go and get law enforcement go and get this patient and bring them in for evaluation. Law enforcement hates these as much as we hate these. what I have done in several situations is, based on your assessment, is I've then been able to call the provider, or you could actually call the provider if it's daytime hours, when a lot of these pickup orders are being executed. You can actually call the provider's office, or we've done that, and said, hey, you know that patient? Well, now that we're actually laying eyes on them, did you know that they actually this, and this? And often they'll cancel their pickup order based on that additional information. That gets to be a lot of time on scene for all parties. It's a pain. But the short answer is, if they otherwise meet our criteria, or they're agreeing to go, quick, easiest thing is to just transport that individual, if appropriate. And if they could go in a police car, there's absolutely no reason that they need to go with us, then that's a separate conversation with them. And if they're refusing and they meet our criteria, then absolutely we do it.
I don't think she met our criteria. She didn't want to go. Her husband didn't want her to go, and he was very bothered by both our presence and the police's presence.
You mean they didn't meet the criteria to refuse?
I think to be forced in.
Oh, they didn't meet the criteria to be forced.
Correct.
Yeah. And then we just, it creates, I'm sure it creates way more additional paperwork for law enforcement and problems for them than for us, because this is a fairly straightforward process for us, and we do this all the time. For them, if they have a pickup order and they can't execute that pickup order, I'm sure that puts them in a very difficult position, but we can't.
Is that what we should have just told law enforcement? Hey, we can't, she doesn't want to go. We can't execute this because we don't have the legal authority to do that.
Yeah.
Okay.
Or you can put them on the phone with us and we can,
Sure.
consortium, I've had those conversations. That was a good one. Start the day. Nothing controversial. What else you guys got? I was just thinking, on my way up here, I was listening to our faculty meeting on Zoom, and we had a presentation from the sexual assault nurse examiners, kind of an update on their program, and there was but the big part of their presentation, fascinating, was on sexual strangulation, which has always been part of sexual assault, but is now also, as I'm sure everybody is very aware, is a consensual practice. Or it may start as a consensual practice and then turns into something that somebody did not think or realize what they were consenting to. And they're SANE is seeing a lot of teenagers now coming in with this issue that, again, they say in some cases they consented to it, but they had no idea what they were consenting to. The next thing you know, they've lost consciousness, and now it's gone a whole different direction. I think the important thing for us, it was really interesting because one of the things they said is that when they ask patients about strangulation, patients often, to them, strangulation is, somebody had a cord tied around my neck. It's like in the movies. It's all dramatic in that sense. They're lifted off the ground, and maybe somebody's behind them with a chokehold and all those things, whereas that's not what a lot of sexual strangulation looks like. But even a hand on the neck, they said that the pressure to cause asphyxiation and loss of consciousness is 1/10 of a strong handshake. So it doesn't take much, and that can absolutely lead to traumatic brain injury from asphyxiation, and can also lead to carotid dissection and damage to the blood vessels. So, and if we don't know about that, then we may not work that up. And anybody who's been to the UNM emergency department recently knows that half of our patient interviews are happening in the the waiting room, or in one of our confessionals in the waiting room. There's no privacy whatsoever. So we're not going to get, in many cases, a great history. So as in many situations, the best history that happens is the history that you all get on scene or in some privacy in the back of the rescue. It just might just put that flag in there to just be alert to that, just like we talk about being alert to trafficking and so forth. be alert to that as a practice, and it doesn't have, because if you're talking to somebody and you're like, hey, was that encounter consensual, and they say yes, that doesn't mean we don't need to have a follow-up question about any, and one of the terms they said is, did anybody, was there pressure applied to your neck? Whether you wanted it or not, was pressure applied to your neck? Did you feel like you were having trouble breathing? Did you lose consciousness or almost lose consciousness? That would be important information to pass on to the next team. Never ceases to amaze me in this business the things that we're talking about that I never thought I would be talking about. If anybody's going to see it, we're going to see it. All right. Well, I guess we'll talk about stroke, and then if people have questions, we'll do that, and then we'll have more time to talk about things with charts. So stroke update, thanks to Dr. White, Sandoval County Medical Director. We share the consortium, we share a lot of slide sets around, so I started with hers, and then modified from there. Let's see if I can actually get slides to advance. That'll be a good start. Okay, well, stating the obvious this early in the morning, strokes suck. They're very common. They are, a lot of people die from stroke, but also a lot of patients, as we know, have permanent disability. Some patients may say that's, how often do we take care of people saying they wish they had died had they known what they were going to deal with for repercussions. So this is a serious problem all over the world, but especially in the United States, we seem to have a lot of these issues. What are the kinds of strokes? How do we classify strokes? Because we love to classify strokes. Okay, ischemic, hemorrhagic, and I'll go with that as probably, there's absolutely other ways to break them up, but I'm going to just go with that as the most common overarching way of breaking up or categorizing strokes. And this is important because when we get down to what we do for treatment and where the patients need to go, absolutely varies. So when we say stroke, patients have all sorts of different ideas of what that means. Just like when we tell somebody, oh, so-and-so broke their neck. If you tell somebody that they broke their neck, if I walk in to talk to a patient's family and say there's a broken neck, I've lost them at that point because that is absolutely in their mind 100% paralyzed. That's what they're picturing, which unfortunately in a few cases is true, but the vast majority of time what we're talking about is a bone that's broken and there's no neurologic damage, right? But what they picture and what I'm saying, two different things. So in terms of stroke, people also have all different ideas and conceptions of what that means. But we're usually talking in ischemic stroke, there's a blockage. That blockage either developed in that specific location or some of that material broke off and embolized to a smaller vessel more distal, or a damage to the blood vessel, a hemorrhagic stroke. Now you can actually break these down a little bit more. So if we talk about the hemorrhagic strokes, there's two major categories of hemorrhagic strokes. There's subarachnoid hemorrhages and there's intracerebral or intraparenchymal hemorrhages, and you'll see that a lot on charts when you pick up patients. It might say IPH, okay, interparenchymal hemorrhage. These, and then there's also other kinds of bleeds in the head, which we love terms, which would be extraaxial, like a subdural hematoma or an epidural hematoma. Those aren't usually strokes. Those are usually from trauma. It may be from a lot of trauma, or it may be somebody who's on blood thinners or has an atrophied brain from alcoholism or something, and they just have a trip and fall. But that's not a stroke because that's not spontaneous. There's some kind of trauma. It still involves bleeding in the head. Doesn't make it any less serious. So subarachnoid and intercerebral hemorrhages. Nobody wants either of these. Okay. Subarachnoid hemorrhage, the most important thing is separating out, and I thought that was really interesting in the slide that they put this here, but head trauma, if you have we see this all the time. You follow up on a patient, on what their CT showed, or maybe an interfacility transport, and you have somebody had any kind of trauma, fall, motorcycle accident, whatever it is, and it says subarachnoid hemorrhage. That is just a little bit of blood that's sitting usually around the base of the brain after trauma, that has almost no significance. I mean, not that we ever want to have blood in our brain, but if that's their only finding, if they're sitting up on their cell phone talking and they have a subarachnoid hemorrhage from trauma, they're going to get a follow-up CT and they're going to go home. We treat that basically like a concussion. If they have a subarachnoid hemorrhage and they didn't have trauma, and they were sitting in a meeting and all of a sudden had the worst headache of their life, and now they have bleeding in their subarachnoid space on CAT scan, we presume that that person had what?
Stroke.
A stroke. Of what happened specifically? It might be on the
Hemorrhage.
screen. What's that?
Aneurysm?
An aneurysm, a leaking or ruptured aneurysm. That, on the other hand, is absolutely an emergency. Okay, because if they're still talking to you with that, we've got to get that aneurysm fixed before it completely ruptures and they're dead. So, just to point out, subarachnoid hemorrhage spontaneous, ooh, that's really serious. Doesn't mean it's not fixable, but super serious. From trauma in and of itself, not that serious. Now, what we sometimes see is the patient's, GCS of 5 with the subarachnoid hemorrhage on their CAT scan. Well, it's not the subarachnoid hemorrhage that's the GCS of 5. They have a diffuse axonal injury, they have something else that happened in their brain. So we're going to separate that piece out. So hemorrhagic strokes can be subarachnoid, and that's really a terrible drawing. That looks way more like a subdural hematoma than a subarachnoid. From either an aneurysm, or it's interesting, has anybody heard of an AVM? So an arterial venous malformation is an AVM. We actually, in New Mexico, have the highest rate of AVM for the population in the country, and perhaps maybe in the world. There are some interesting congenital causes of AVM that run in families, especially some of families that have long lineage, Spanish lineage, and it was just passed down, and they have this congenital issue. And people, because people marry and names change and how people's appearance may change, it may not fit that family stereotype looking at them, so you can't always tell that they may not even know that they have this in their DNA, but we have an incredible incidence of AVM in New Mexico. So these cause spontaneous, now these also can cause spontaneous intracerebral hemorrhages too, subarachnoid or bleeding that's inside the brain itself. Okay, intracerebral, intraparenchymal hemorrhage. These are often associated with chronic untreated hypertension. So that is subcategories of stroke. Now, if we look a little bit more, just of interest, for these aneurysmal bleeds. These aneurysms tend to be at the base of the brain, and when you get a CAT scan of what this looks like, this white is blood in the subarachnoid space. It's at the bottom of the brain. It's not kind of on the outside of the brain like that other picture would make you think. It's usually sitting on the bottom of the brain. And then somewhere, they usually have this little aneurysm, which is a congenital thing that people get. And those aneurysms are, maybe about a centimeter in size. Sometimes they can be quite a bit bigger than that, but they're not generally huge, because if they're huge, you would have other symptoms because of the confined space in your brain. So if you catch these before somebody is neurologically devastated, they can go in, either a neurosurgeon goes in and literally puts a little clip across it. It's called clipping the aneurysm. If they can get to it surgically, or if they can't get to it surgically, they feed a wire up, just like we feed wires into the heart. For a heart attack, you feed wires up into the brain, and they put some material inside a coil to fill up that aneurysmal space. There's clot around it, and it prevents it from being able to rupture. So this is what we want to have happen. And this is going to affect our treatment a little bit that we'll talk about, especially for interfacility transport. So this is an aneurysm that's been protected. Okay? This is an aneurysm that is not yet protected. if we talk about going now back to the ischemic strokes, so we talked a little bit off the hemorrhagic side. Take it back, not the slide I was. This is obviously more hemorrhagic stroke. This is kind of like this because they actually kind of gave you an illustration of exactly what you're seeing on the CAT scan. This is a large intraparenchymal hemorrhage. This one is pushing on ventricles. There's swelling around it. This is a much smaller hemorrhage. Is this worse than that?
Yes.
It's not all the size, it's the location. So depending, if you have a very small hemorrhage down near your brainstem, like in the center that controls your breathing, for example, a very small bleed can be fatal. And sometimes on these, if you have a non-dominant hemisphere bleed, sometimes these patients end up with remarkably minimal deficits when it's all over. So the size and the location matter with these bleeds. So just, if you're looking at a CAT scan on a patient and it's a little bit on transport, you don't always, on these interfacilities, know where these are going to end up. Okay, now back to ischemic strokes. This is the majority of strokes. And it used to be there wasn't much we could do, and I think everybody knows now that we have some options for these strokes. What's interesting though, what really matters a lot, just like with the bleed, it's the size of the stroke and the location. Same with ischemic strokes. It's how big an area is affected and what area is affected. Dominant hemisphere, non-dominant hemisphere. Is this affecting the part of your brain that controls your vision, your speech? What area is it? And if you think about the blood supply to the brain, which is remarkably complicated, and down here at the base of the brain we have the circle of Willis, which is where all those aneurysms tend to occur. We have major vessels, like anywhere in the body, that sort of eventually they start branching and they get smaller, and they get smaller, and they get smaller. So if you have a little clot that breaks off, a very small clot, and makes its way out to a very small little artery in the brain, if that, depending on whether that area is controlling something supercritical or not, the symptoms can be relatively minimal, maybe more or more profound depending on the area. But if you start getting strokes that are in these bigger vessels, right, everything beyond them is at risk. And those are what we call large vessel occlusions. Very complicated terminology. I can explain how we came up with that term if you'd like. So every once in a while in medicine we make something simple. And this one we made simple, right? Large vessel occlusion. What's interesting is that the treatment for large vessel occlusion is a little bit different. So our standard clot-busting drugs that now almost every family member and patient that I talk to has heard of clot-busting drugs and understands. It's not just TPA anymore, but that's certainly the one people hear about the most, but there's also TNCase, which we use quite a bit. These have a great impact on smaller strokes. They can still be very significant based on where they are, but small clots, it just makes intuitive sense that if you're trying to use a drug to dissolve a clot, and these drugs don't just go in and literally dissolve the clot, they really help your body break up the clot. It doesn't.
Touch the middle
Tap the
screen.
middle
Touch the
screen.
middle one.
Middle screen.
Middle screen. I don't follow directions very well. So I was thinking middle of screen, sorry. The smaller this clot, the better chance you have of actually dissolving that clot. Well, if you start having a really big clot in one of these big blood vessels, the TPA or TNCase may help create a little flow around it, which is huge, but it's probably not going to just completely open up that blood vessel. So we have to think about other therapies. So I think people are familiar with the idea that earlier is better with the medicine, which is why we talk about stroke alerts and trying to get patients places early. We still have not been able to make this work past 4.5 hours from what? Onset. And the term we often use, I heard somebody say it, is last known normal. But it's the onset time, right? Or people say last known normal. And that can be really hard to just know when that was. Sometimes we know exactly. Literally, they were standing there, they were eating, we were having a normal conversation, boom. Okay, we know when last known normal was. They woke up and they were fine when they went to bed, and they woke up with this. That's a little more complicated. We have some more options than we used to have for those patients, but in general, TPA, or not just in general, clots, these medicines we cut off at 4.5 hours. We prefer less than 3 hours, but the truth is we prefer like an hour, like 30 minutes. Whatever we can do earlier is better. And we still do this for large vessel occlusions to get things going, but it's not the end of the game for these large vessel occlusions. So we must, in order to give any of these treatments, but especially TPA, we have to know when they were last normal. And please, just a reminder, bring a family member with you who was there, if at all possible. Sometimes people bring like the family member that's the calmest and nicest and whatever, but not the one who was there. So that sometimes doesn't help us. Or a phone number for that person. But I can't tell you how many times we have had down at UNM, and we see, Comprehensive Stroke Center, stroke alert after stroke alert after stroke alert, many of which aren't stroke alerts, don't turn out to be strokes, appropriate stroke alerts. How many times somebody comes in and is like, when was the last known normal? I think it was around 12. Well, do you know? No, well, we just wanted to get them here quick. So with the best of intention of trying to get somebody to treatment quickly, sometimes we're never able to offer them treatment because we are not able to track down a family member. And if we don't know for sure, the default is no treatment. It's not, oh, we're going to take a chance. Even if it's a devastating stroke, the expectation is industry standard. If you don't know, no treatment. So if it takes you an extra 5 or 10 minutes to track down a family member, whatever it is, it's worth it in the long run. Or leave somebody on scene, which works great. You start transporting, leave the engine on scene to get that information. Whatever it is, that is a huge benefit to us. All right, now, large vessel occlusions, this really isn't the end of the road. We now have these really amazing treatments that is what's called endovascular therapy, where talk about feeding stuff into the brain. This is not just like feeding in a little wire to open up a blood vessel. You're feeding in rotor-rooter. And they're literally able to go in and manually retrieve the clot. They try not to break up the clot. They try to retrieve the clot. Why do you think breaking up the clot may not be ideal? Yeah, exactly. Now you just send a whole bunch of emboli downstream and you end up with a whole bunch of little strokes. So the whole magic in this is being able to figure out how to feed something through, block, pull back, get the clot out. And the technology is getting better and better in terms of what they can get to in terms of smaller and more distal strokes. But right now, it has to be a fairly large vessel occlusion to do that. When you can do it, it is, one of the studies would say they found that they only have to do this to 4 patients to save 1 bad outcome. There's almost nothing we do in medicine that, that's as good as that's probably better than a VFib AED defibrillation. That's pretty damn good. So this is a real important thing. Now, what's also cool about this, or important about this and cool, is that this is not restricted to 4.5 hours. Because the reason that we're restricted to 4.5 hours with the clot busting drugs is because the longer you go, the higher the risk that the patient's going to have a massive hemorrhage from the medicine. Because basically, as the blood vessels themselves aren't getting good blood supply, the blood vessels weaken, and now you put this in and you end up with a massive hemorrhage. But that's not the case with the endovascular therapies. So what we do with these patients is when they come in, and a patient comes in that's outside the window for TPA, or has already gotten TPA at an outside hospital, but they're within 24 hours, which now means everybody who woke up with a stroke, right? We get what's called a CT perfusion imaging. So instead of just getting a CT scan to see if there's bleeding on the head, oh, bleeding on the head, it's a hemorrhagic stroke. Probably shouldn't give a clot-busting drug, right? Now we get a CT angiogram where we inject contrast and we look to see, is there a blockage in one of those big vessels? Yay, there's a blockage in a big blood vessel. Yay, it's less than 24 hours. Now we get a CT perfusion study that actually shows us what part of the brain is already beyond help and what part might still be salvageable. So crazy technology. So it actually shows you basically the classic penumbra that we've heard about. Here's the core infarct. But there's actually a fair amount of tissue around it that's still salvageable. We're going to go in and do what we call a thrombectomy and take out that big clot. Or it's only been 6 hours, but you know what? It was a complete occlusion. There was no collateral blood flow in that patient, and that brain is already dead. So we have patients that come in at 6 hours, and there's nothing we can do on thrombectomy. But now we have these patients who wake up. The last known normal was 8 hours ago. By the time they make it through the system, we're getting these imaging at 12 hours. Oh, there's a lot of brain still salvageable. It's a large vessel occlusion. It's in a place they can get to. We go up and we do thrombectomy. Pretty crazy, yeah.
How long is the perfusion study? Is it like the same as getting a CT?
It's pretty damn fast. Yeah. So when they come in, when you roll that patient in at UNM into CT for a stroke alert, and you hear people kind of like the different orders. It's, are we getting just a CT? Are we getting a CT angio because we're concerned about the possibility of a large vessel occlusion? And you'll hear sometimes people say CT perfusion. It's all based on the time frame of the symptoms. Yeah.
Is it detrimental after 4.5 hours to be given a clot buster?
Well, potentially, yes. And that's the reason we don't do it is the risk to benefit ratio. The moment, if you get a clot busting drug at 10 minutes, if that's, I don't know, if that's somehow theoretically possible, high likelihood of dissolving the clot, very low likelihood of causing bleeding. There's always a risk of causing bleeding with those drugs, but it's relatively low. As time goes on, and more tissue has already died, and the blood vessels are getting more damaged, the clock starts going less benefit, because more neurons are already dead, more risk of bleeding. It used to be 3 hours we felt was the cutoff. We changed the dosing of the agents. That's what pushed us out in large part to 4.5 hours by changing, the studies changed the dose regimens of the TPA. That got us to 4.5 hours. There could be a study that comes out tomorrow that says, hey, if you change the dosing to this and you add a dose of this, you can take it to 6 hours without, and every family and patient have a different threshold on what the risk is of bleeding. I mean, like anything, you talk to the families about this, they're like, if you tell the family, it also depends on the symptoms. If somebody has, their only symptom of their stroke is weakness of their non-dominant arm, and you tell them that there's and usually the number we quote is, at baseline, is a 5% chance of serious bleeding in the brain. They might be like, yeah, I think I can live with this, I'll just carry it around. And you tell somebody who's like, facial droop, they can't talk, they can't communicate, they can't walk, 5% risk suddenly seems really good, right? And it does change a little bit as the time goes on.
Is this procedure only at UNM?
Okay, so that gets back to, couldn't have asked for a better lead in here.
But you pay him to ask that question?
All right, so most hospitals now can assess for ischemic stroke, get the CT to say there's nothing else going on, Often there's a teleconsult with a neurologist to help confirm that everybody agrees that this is really likely a stroke, worth the risk, and they can give TPA or TNKs. Most hospitals now can do that. Right now, endovascular therapy is only available at UNM as the Comprehensive Stroke Center. There was a bit of a time where Press Downtown had it. There was a bit of a time where Loveless had it. It's a moving target. But if you're going to have somebody feed a wire into your brain and try to get a clot out without rupturing the vessel or causing more stroke, you want the person that does the most of these. So you want a high volume center. So I hope that, I'm not invested in whether that's UNM or Press or Loveless, but it makes sense that a region have one place, and if I found out tomorrow that, hey, they're gonna shift, the Comprehensive Stroke Center is gonna shift to, Press Downtown, I'd probably do the happy dance because I see so many stroke alerts at UNM. It'd be like, okay, I cut down the number. I just want to have a Comprehensive Stroke Center in our community. So the question is, how do we get people to the right place? So the first thing is we have to identify that we think somebody's having a stroke. This is your basic assessment of the patient, right? How many times have we seen stroke mimics? Classic one like hypoglycemia or something. We see all sorts of things. But you have to assess that you think somebody is likely having a stroke. And we use the Cincinnati Stroke Scale still as kind of our standard assessment tool for this. It's not perfect. There are plenty of patients that have confirmed strokes that get treatment and their stroke doesn't show up well on the Cincinnati Stroke Scale. But it's pretty good. So step one is identify that you think somebody's having a stroke and that they have a positive on the Cincinnati Stroke Scale. If you really think that somebody's having a stroke, just because the stroke scale isn't positive, by all means, treat it like a stroke. In those patients who you now suspect are having a stroke, we have to go the next level and determine, do we think they're having a large vessel stroke? Because that absolutely, in our system, will change where you transport. If you're in a system where there's only one receiving hospital and the receiving hospital is a comprehensive stroke center, or there's no comprehensive, or nobody does thrombectomy, you don't have to go to this next, it's just not going to change your management. But for us, it absolutely does change our management. And there's a bunch of different scoring systems that are used for trying to figure out who has a large vessel occlusion. So step one, Cincinnati Stroke Scale, you guys own that, I'm not going to go over that. The next step, I don't know why it says step one, because that's really step two, is apply, in our case, we're using CSTAT. Now, if the patient didn't flag positive for Cincinnati, you don't have to do a large vessel score. So, do you think they're having a stroke somewhere in some kind of vessel? Yes. Now let's see if we think it's a large vessel stroke. Do you think they're having a stroke in some vessel? No, probably not. No point in looking to see if it's in a large vessel because we don't think it's in any vessel. We've been using the CSTAT in Sandoval County for a while. And so it's a scoring system that people are pretty comfortable with at this point. It's pretty easy to apply, and our plan right now is to keep using this score. And actually I use this score myself because it's so easy in my mind to just apply when I'm seeing patients coming in and I'm trying to decide quickly, am I going down the CT angio pathway and all that for large vessel occlusion. I use this scoring system. So 2 or greater, we're concerned about a large vessel occlusion. So the gaze part is conjugate gaze paralysis, so inability to direct the eyes in one direction. So they can look over here, but they can't go over here, or they're just fixed in one certain direction. That's bad. And that's one of the things I like about the CSTAT score is all the things in there kind of are intuitively bad. Like if you walk up and you look at somebody and they're just fixed over in one way, you're like, that seems bad. Right? arm weakness, like profound arm weakness, yes, this is part of the Cincinnati score, so it kind of duplicates that. But if somebody like cannot hold up their arm, seems significant. And of course, if you're having a stroke and altered mental status, because most strokes don't cause altered mental status. You may not be able to answer the normal questions because of aphasia, but you're alert. You're not altered. So if you can't, do these things and follow commands then that is a concern. So identify whether you think they're having a risk for having a stroke. Cincinnati, if it's positive, let's go on to another scale. Now, let's look at some of you who have worked in other systems, especially worked in Albuquerque or still do, know that there are other stroke scales out there. This is not all of them, but the last study in 2021 looked at these 9 different stroke scales. These are scales for large vessel occlusion specifically. Because people are trying to figure out how do we identify these patients in the field and triage them to the right hospitals. Because the people that run thrombectomy programs want to get thrombectomy patients, but don't want to be bogged down with all the other patients. And if you run a hospital that's not a thrombectomy center, you want to make sure you get your fair share of all the other strokes that you can take care of, but you don't want to get the thrombectomy patient that you then have to transfer to another hospital. So everybody is invested in trying to find the best scale. And I don't expect anybody to spend a lot of time understanding receiver operating curves, but which is a way of sort of saying how good is a test. When we talk about balancing, how good is it at recognizing something and how good is it at ruling out everything else, sensitivity and specificity, you can plot those against each other and get something called a receiver operating curve. The important take-home point is that these numbers are really close together. So if you look at the C-stat, overall, it's on this receiver operating curve score is 0.75. The LAM score that they're using, that Albuquerque switched to, is 0.79. It's like, and I've asked the stroke people downtown, I'm like, do you really want us to switch what scale we use? And they're like, no. At this point, there's no scale that is so clearly better, and the ones that are a little bit better are often way too complicated for anybody to use in the pre-hospital system. It's just like you have to literally have a score sheet and you're going to spend all this time on scene that just doesn't seem realistic for us. So right now, there's no system that's better than another. None of them are fantastic. These kind of numbers, 0.75, 0.79, you're not going to pick up all of them.
Those
And
are
you're going to
percentages.
and you're going to pick up some that are going to flag positive that don't end up being a large vessel. But it's a pretty good screening tool, but I don't personally care which of the screening tools you use. Because most of the time when you're talking to dispatch anyway, you're not saying, some people are, C-stat positive, LAMS positive. The simpler thing to do is to just say positive LVO screen. Because that's what comes across in the text that goes out to the stroke team. A lot of times there's residents that don't even know what all the different scores are out there. They just want to know, is this a potential LVO or not? Because it depends on who they activate in the system. So if you just call dispatch, if you did the LAM score and it was positive, or race, or one of these other scores, fantastic. Just say, whether you say LVO screen positive or concern for large vessel occlusion, whatever you say, that's going to set things in motion. But more importantly, it's going to determine where you take people. So, if you have somebody who you're concerned, this is all only talking about patients who you think are having or have had a stroke. That's all we're talking about. Not every altered mental status patient. People who you have a reasonable suspicion are having or had a stroke. If you don't think it's an elbow, okay, and it's less than 24 hours, in general, in Rio Rancho, we're going to go to Rust. If you're up in the 550 area where it's almost as easy and you're going to have to decide on traffic and all those other factors, you're like, it's almost as easy to go downtown, great. Go downtown to a core hospital, might save the patient a secondary transport, and it's not gonna cost them a whole lot of delay to getting TPA if they need it. Great. In general, in Rio Rancho, we're gonna go to Rust. Less than 24 hours, and so we're time, but it's not a concern for an ELVO. If you think they have an ELVO, Cincinnati positive and CSTAT or whatever screening tool you want to use, if it's less than 24 hours, because that's our window, go down to, right now, UNM you need to take them to a comprehensive stroke center that has thrombectomy. That could, again, we could have an email tomorrow that's like, oh no, we got another thrombectomy center. All right. So that's real important. Now, a few caveats. If you have a patient who you think is having an ELVO, and this is where the details are, we still like to give those patients TPA. While we're setting up, calling in the thrombectomy team, getting all that imaging and doing all that stuff, we want to be trying to break up the clot. They can still go in and do the procedure. It used to be they thought that once you've given somebody the clot-busting drugs, you can't poke the blood vessel and you can't feed the wires up and it's too risky. And now we know that it's fine to do. So if you're pushing that time frame, like you're in one's area and you can see rust and you're really sure that it's an ELVO, but you're at like 3 hours and 45 minutes and you're like, by the time I get them downtown and they get a CT scan and all that, we're gonna miss our window for TPA. Might make sense to just stop at Rust, let them do the workup, let them give TPA, and if it does turn out to be an ELVO, they can do a secondary transport. The problem is those secondary transports often add a couple hours to the whole process, which isn't great for their brain. So that would be, to me, the main exception. Yeah.
Sorry, Doc, just a couple slides before we said it was a non-LVO. We're thinking it's a non-LVO, less than 24 hours. It falls within our TPA window. Is Loveless Westside still an appropriate facility for Loveless patients? Because
So right now,
they've taken some, they haven't taken some.
right now we would like our TPA candidate patients to go in, that aren't going downtown, to go to Rust. Loveless and SRMC technically both have capability of doing teleneurology, both have TPA on formulary. The problem is that neither of those centers have enough volume of patients to have been able to show us that they have a timely process in place. Would I fight with a patient over it? No. I would say, hey, we're supposed to take patients that are, that we think are having a stroke to Rust. And if the patient's like, absolutely not, my insurance, I have to go to Loveless, then fine. But I don't offer that to them up front. Same with SRMs. And if it's greater than 24 hours, they're no longer a candidate for any of these therapies, so just take them to the closest appropriate facility. Now, another important point, if you think they're having a bleed, bleeds almost always end up getting transferred downtown, and a lot of the bleeds end up at UNM because of some of the kind of advanced neurosurgical interventions. So if you have a patient who has a lot of strokes, have high blood pressure, the brain is trying to force blood through constrictions. We don't want to mess with that. But if most strokes don't have headache, so if you have a patient who has headache that came on like that, and especially if it's associated with high blood pressure and a change in mental status especially, and I'm not talking about somebody who has, oh yeah, it's just like my migraines now, right? But I mean, you have that person, you walk in the room and they're just kind of sitting there like this, and we had somebody brought in the other night that was 29 years old, just abrupt onset of headache, comes in just like drooling. We ended up having to intubate him before we could even send him a CT scan. That's like, and his blood pressure is like 200, so it's like high chance that that's a bleed. If you think you can safely get that patient to a core hospital, that's almost guaranteed that's where they're gonna end up. Now, if you think that patient needs an intubation before they can go downtown, yeah, of course, stop at your local closest hospital. But if you're like, I have a bad feeling about this, those patients are all gonna end up getting transferred secondarily, and we're probably gonna end up doing it. So if you can get them downtown, that's great. Yes.
This might be a dumb question, but
Yeah.
for cases like this where sudden onset, pretty high likelihood that it's a hemorrhagic, would we consider TXA before transporting?
Great question. So the answer is no, and the reason for that is we don't use TXA for these in the hospital either for stroke. There's controversy in traumatic head trauma, but a lot of these patients, if you get, the challenge with TXA is that it can cause clots. The reason we don't give it beyond 3 hours in trauma is because the risk of causing a clot outweighs the benefit of stopping bleeding. If this started as an ischemic stroke that then secondarily bled, which some of them will do, and they have a clot in their vessel, and we give them a medicine that's going to make them clot more, we could cause more problems. So TXA is not considered, it's a great thought, but it's not even on, even if we know, we don't give them that.
Okay.
Yeah. A lot of controversy around TXA these days, but all right, so I'm going to tie onto that, just finish up here, and then we'll take a break. Talk about secondary transport. I thought I would put in a few slides and start. I feel like we need to start doing more education around interfacility and critical care transport. I'm guessing you're all aware that we're doing more of these. So, we are not suddenly noticing more resources in the system to help with this. So, interfacility transports are not going away. So, so adding in some education. So let's talk a little bit about the interfacility transport of the stroke patient, because this is a potential, one of the things we deal with a lot is getting called for patients that really require a critical care transport team. We are not. And so people in this room are more than smart enough to be able to do critical care. And some people in the room have done or are doing in other jobs critical care transport. But part of the issue is that the community standard for critical care transport is 2 critical care trained medics in the back caring for the patient simultaneously. So even when we have somebody who's on who is critically care trained, we almost never have 2 critically care trained people to put in the back with a patient. We've talked about it as a department. We would love to be able to staff a critical care transport team, but that's very expensive to have enough people trained and to always have 2 people available to be in the back, plus the ongoing training and the equipment. So it's an ongoing conversation with department leadership as we see more and more of these requests. But understand, when we talk about critical care, it has nothing to do with, are you guys smart enough to do critical care? It's, do you have the training, do you have the personnel, and do you have the equipment to do critical care? But as a 911 agency, we're always the last call, or often the first call, for emergencies. So what we've said is if there is a patient at a facility that clearly needs a critical care transport team, and there is nobody else available to take that patient in the timely manner that they need, then we will consider doing those transports, because we're now held to a very different standard. We're not advertising ourselves as critical care. We didn't, say, call us for your critical care transport. 911, what's your emergency? I have a patient who has to get downtown in the next 30 minutes. Well, did you try the critical care? Did you try a flight? Nobody else is available. All right, on our way. Now, when you guys get there, you're going to make a decision of, wow, I don't actually feel comfortable transporting this patient, and I think that this patient could probably wait another hour for somebody who has more equipment, a better ventilator, pump, whatever it is. You guys make that decision. Call the MedCom if you have a question. Call me. Call the consortium. We'll help you with those decisions. But just understand, if you end up taking a patient who is in your scope of practice, let's be clear, we're only talking about things that are in your scope of practice. But if you end up taking a patient that is really outside of your standard transport, but nobody else is available to do it, and they clearly have a time urgent problem, nobody is going to hold us to, if somebody has a complication because we didn't have the right ventilator and all this, it's like, well, you know what? We did what we could. So don't feel bad about taking those patients either, but don't feel pressure to take them if it's clearly, it's like, did you guys call PHI? Did you call lifeguard? Did you call anybody else? No. Well, what's wrong with the patient? They're having a stroke. Okay, what kind of stroke? And I was like, oh yeah, I got this. They need to get down, we can do this. Or, wait a second, what's their mental status? What did you just say? So, and we'll talk through a few of those things. Chief, you want to add anything?
Yeah, when Dr. Braude says, we ask if they call PHI and all that stuff, that's on the back side. That's not the crew responding to the IFT. At that point, you've already got a call, you take the IFT. If it's within your scope and you're comfortable, all that good stuff, all those boxes are checked, then we will follow up to make sure that PHI, Albuquerque, and all those boxes were checked prior to them calling us.
Good point. And one of the reasons why there's a QA indicator and that we review these transports is to make sure that the system is doing what the system is supposed to do. And so we will follow up with them and say, hey, this transport we did the other day, it went fine, but really seemed like this should have gone to a critical care team. Did you guys call? What was the process?
Not to derail the topic, but we had a crew who had to go to SRMC the other day to pick up someone on the 4th floor for a tooth abscess. I mean, is that something that's also being followed up on, those kinds of things?
I don't know about that one in particular, but in general, yes, absolutely. We look at them on both sides. We look at them calling for patients. It's rarely an issue of them calling for a patient that's too sick for us. You guys do a great job. The vast majority of these transports, you guys take care of just fine. But we also don't want the crews, taking patients that clearly could have waited, longer for Superior or AMR or somebody else to come and do that transport. So when I hear about those, yes, we follow up and try to figure out what was the process. Because the inpatient side often doesn't know about these other resources and what they're supposed to do. So, but I agree, the simplest thing when you're there is just smile, get the patient what they need. There's nothing worse than the patients, and I deal with this on the lifeguard side a lot, when the patients hear these discussions outside the room of and then we get the complaint later, and I was like, I paid my tax dollars, I did this, why would they not just take me? And they don't understand all these little details that we're dealing with. But yeah, it's important stuff. So let's ask this next question. So you get a stroke call, you go into to take a patient, and the IFT stroke. What kind of questions do you have? What do you want to know?
Ischemic or hemorrhagic?
Yeah, what kind of stroke? What else do you want to know? What's that?
If their baseline that has been presenting with the hospital.
Yeah, so both their true baseline and what their neuro exam and deficits are now. And that is an important distinction, because I can't tell you how many times we have patients who've had prior strokes and other things, and they come in and they're all weak on one side, and then we go to the chart, and you're like, that's how they always are, right? So it's nice if you actually somebody will give you that information or you ask. Great, what else? What's that?
If they were given thrombolytic.
Yeah, what were they given? Absolutely.
Are there interventions done?
Yeah, what's been done? I would just add a few other things to that. I mean, that's a good list. So, what are they going for? Right? Is this a patient who is going for, just general post-stroke care this is a patient who's at Loveless West Side and they don't have the rehab and PT and all these things there. They want the patient to go downtown. Or is this a patient who's going for thrombectomy and they're now 12 hours into their stroke? Okay, but very different time urgency. Nice to know, in addition to whether they got medicines, is the patient on any other anticoagulation at baseline? Because if they have a hemorrhagic stroke and they're on Eliquis, that's important to know. And did they already give medication to reverse that? It may seem obvious, but it doesn't always happen. Doesn't mean you're going to wait on scene for them to figure out how to do it, but all of a sudden this became a much more time-urgent transport. And then this last thing I think is really important is this idea of blood pressure targets and goals. And this will be almost the last slides here. So we have reasonable evidence in certain circumstances for certain blood pressure targets for patients with stroke. But there's lots of different kinds of strokes. And I don't expect you to commit these to memory because they also change all the time. So it's just important to ask somebody before you go, hey, is there a blood pressure target for this patient? Now, the patients who have the lowest target are the patients who we think has an unprotected, unclipped aneurysm. That's a time bomb. We try to keep their systolic blood pressures below 140, and I push it even farther if I have especially if I have an arterial line and I have a drip, I'll push that even lower. The next strictest category is somebody who has the intraparenchymal hemorrhage. Excuse me. Generally, most people agree 140 to 160. Now, does that mean that like we panic at 165 and their head's going to explode? No. Generally, we also don't want these patients to get what? Hypotensive would be devastating also. So it's just a rough range. Now, patients who've had ischemic strokes who have gotten lytics, you have to keep their blood pressure a little lower than patients who haven't because of the risk of bleeding after thrombolytics. But these are still pretty high numbers. A patient who had an ischemic stroke that came in at 4.5 hours and was outside the window, we let their blood pressures go really, really high because the assumption is narrow vessels, they need that. So just keep in mind that the blood pressure targets change a lot. Ask somebody before transport, what's your target? And if there is a target to lower the blood pressure, what is the medicine for the medics in here that we're seeing most commonly now? If you're going to have a patient who's on a drip, what are you going to see?
Like metoprolol?
So beta blockers sometimes get used, but it's not kind of the go-to now. The go-to is nicardipine. So nicardipine, Cardine is a calcium channel blocker. Usually it's 5 milligrams an hour, max of 15. You go up by 2.5, roughly every 15 minutes, or down. Don't let the patient get hypotensive. It works pretty fast, about 5 minutes, it'll work. However, when you turn it off, it doesn't, you don't even see, it takes 30 minutes to see about a 50% decrease. So you don't want to let them get hypotensive and then turn it off. They'll be hypotensive for a while. But now this is a great medicine, but you want it on a pump. And this is one where normally a critical care transport team will take a patient who's on Cardine, but we can't. It's scope of practice, and we have transported quite a few patients now on Cardine. I'm going to save questions till after the break so I can take care of this. So, how long did? Oh, Eric left.
No, he's right there.
Oh, there you are. How long do they have?
For a break, let's do 10 minutes.